Program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Jeff Mcquillan serves as NCO's Healthcare Senior Vice President of Revenue Cycle Management Solutions and Services. In this position, Jeff is responsible for developing advanced software and services for clients and executives oversight of the HIM division. He is a seasoned executive with more than 30 years of experience in the healthcare industry. He has an exceptional track record in HIM management and marketing, which has spanned positions at companies including Lanier and MNet, the current McKesson HPF application. He is the co-founder of eWeb Health, which was the first company to offer remote coding technology. We also have Thomas McCormick, an Associate Vice President of Patient Accounting, University of Pennsylvania Health System. Tom's responsibilities cover both the hospital and physician accounts receivable operations that include 3 hospitals, a 600 physician faculty practice plan, and a 200 physician primary care group practice. He has been in healthcare for 30-plus years. Tom is also a board member of the Philadelphia chapter of American Association of Healthcare Administrative Management. It is now my pleasure to turn the floor over to Jeff to begin today's presentation.
Thank you very much. I appreciate everyone's time, and I hope you find the presentation informative and helps you with your practices. I'm happy to be on the call with Tom. University of Pennsylvania has been a great business partner with us for the last couple of years. They're a good team to work with, give us some honest feedback, and it's been a true partnership and a pleasure to work with Tom and his team. As you can see on the presentation slide, which goes to the University of Pennsylvania Health System, it's a decent-sized health system based in Philadelphia, Pennsylvania. And the last bullet does show that it's the first hospital in the country. I'll give the slides a minute to catch up.
Yeah, Jeff, while those slides are catching up, I just want to point out that in the health system, the Pennsylvania Hospital is the first hospital in the country, and we like to call the mothership, Hospital University of Pennsylvania, is the first teaching hospital in the country. But here in the Delaware Valley, everybody thought we were just running around buying hospitals that started with P. Pennsylvania, Presbyterian. At one point in time, we actually had Phoenixville Hospital. But now we're just down to the 3 hospitals. So it looks like your slides have caught up.
Beautiful. Thank you. The next slide is just a quick overview of who NCO APAC is, and just pointing out a few key functions. It's just the size and the scope of the organization allows us to manage facilities of the University of Pennsylvania size with seasoned people who are used to working with that size organization in large engagements. With over 42,000 employees, we offer both onshore, offshore, nearshore, and at-home models depending on what the client's needs are. The next slide just touches on some of the health information services that we offer as NCO. And what we find is more and more organizations are focused on shortening the revenue cycle and finding ways to convert their charges to cash as quickly and as efficiently as possible. We see the space moving to Tom's level, CFO levels, and not just in HIM departments, which certainly are a key component of what we do. It's no secret that the healthcare industry in general is suffering from staff shortages at many levels, not just in nursing and in coders, but pharmacists, radiology, and a number of different areas. The next slide does try to address what is forensic coding. And forensic coding is actually a term coined by one of our clients. And what we do is look and have a detailed analysis of, in many cases, denials and why they occurred. In a lot of our clients, either the amount is too small for them to effectively or cost-effectively go after. In many cases, they simply don't have the manpower to take a look at these. Reasons can include, medical necessity and required modifiers that may not be present. Some of the benefits on the next slide of forensic coding that NCO, in particular APAC, is able to address and that we provide back to our clients is documentation that helps them reduce the number of claims and the number of accounts that we work for them. We're strategically integrated not only to the medical record or HIM departments, but the billing and the financial offices as well, and work with their teams on a weekly basis to give them a proper feedback that they might be looking for. The next slide is as an APAC coder. The people we use are coders, not billers. In many cases, they are RNs, so they've been educated in pharmacy and pharmacology, anatomy and physiology, and they have one of many degrees that are required to do the type of work they're experiencing at the University of Pennsylvania. All have at least 3 years experience in this industry, and we feel very good about our employees and the jobs that they're doing with our clients. The next slide does touch on what everyone's been speaking about for a couple of years, which is obviously the impending 2014 I-10. The number of diagnostic and procedure codes has been well documented, the effect that this is going to have on our industry as a whole. And again, the heavy reliance on existing employees in hospitals to get re-educated or to take a closer look at their backgrounds and comfort level with anatomy, physiology, and is certainly becoming apparent for not only the coders, but the physicians as well. The next slide is just an example of, this is stats from the first quarter of 2012 for Medicare denials. 174,000 were in Q1 alone, and of those, only 63,000 were actually appealed for a number of reasons. But the point being that there's, 60-some%, 110,000 appeals from Q1 alone that were not appealed. The next slide is just a quick poll we'd like to do for the attendees that are listening to this conference, well over 140. What percentage of denials does your organization internally pursue? We'll just give you a few moments to take a quick poll, and then we'll let you know the results of the other people on this call as well. Any more votes coming in? I appreciate those of you who took the time to vote. As you can see, we've got a pretty good group, meaning 50 to 76%, or 50% of the people on the phone are in the 76 to 100%, which is a significant amount and certainly higher than what we saw as an industry in Q1. Those figures were from Medicare alone. But we still have another 50% of the individuals on the phone that, as you can see, are down around the 26 to 50%, some on 11 to 25%. So the forensic coding that we do is geared towards addressing the claims which have not been appealed. The next slide you'll see is just another example of that. And I'll wait for the slide to catch up. But back to the first one, only 36% of those in that example we showed where they appealed. But of those appealed, 75% were overturned, which indicates that the percentage of success is pretty high, and we believe that there's a lot of money our clients leave left on the table. If we're only looking at 36%, but of those, 75% are positive for our clients, we think that's a good opportunity for our clients to look a little closer at. The next slide shows that medical claim denials are on the rise. The next slide just indicates that this is a reverse of a downward trend that we saw in 2008 and 2011. And we believe that this trend will continue in the healthcare industry. The next slide does identify health insurers, meaning every private health insurance except Humana increased denials this year. And as you can see, Anthem Blue Cross was the highest, while Regents had the lowest denial rate. I'd like to turn it over to Tom and let him walk through what he's found in working with us.
Thank you, Jeff. So that environment that you just described about denials is exactly where Penn Medicine was about 2 years ago. And I'm certain that it comes as no surprise to anyone listening into today's webinar that denials are increasing among all payers, and specifically in the outpatient arena. As we've seen that as payers become more sophisticated in screening claims, providers really need to step up their efforts to produce what I like to call the ever-elusive clean claim that everyone seems to be searching for. Gone are the days where just a valid ICD-9 code would be enough to get a claim through the front-end edits. And providers really need to carefully scrutinize all claims prior to submission. We need to really expand our use of CCI edits, focusing specifically what we've seen at Penn on the matching of the diagnosis to the service for medical necessity and the correct use of modifiers, as Jeff had mentioned before. As an academic medical center, we frequently get caught up in the trap of medically unlikely edits, specifically in the use of our cancer treatment drugs, where we have instances where we believe these edits have not kept pace with treatment protocols. As a result, the only way to get paid for these is through the appeal process. And as you can all imagine, cancer treatment protocols are very expensive and therefore worth that effort. The problem that we've identified is that all of these outpatient services occur in numbers that are too big to handle with our current infrastructure. And in this current slide, you can see where it all adds up. Most facilities are set up to handle the volume of appeals on the inpatient side of the business, but few are prepared to handle the kind of volume you can get from outpatient billing, particularly where you do 3 million visits a year as we do here at Penn Medicine. There was a time when my shop could actually handle these outpatient denials simply by providing that medical record to the payer and hope for the best. But back then, the volume was relatively low, as Jeff had mentioned in that 2008 to 2011 slide, and the issues that we were facing really weren't as complex. But with the level of sophistication that's been achieved by the payers, the outpatient services are getting the attention because in the aggregate, our numbers are becoming very significant. It's important to mention that the level of expertise that we need to resolve these edits and denials has really risen above the average of the average follow-up staff in the back-end billing office. It needs to be a person who understands both the coding and the billing side of the business if we're going to be successful. It's really why the title of forensic coding is actually so appropriate for this process. Can we have the next slide, please? So to illustrate this point, what you have before you are the resolution steps that we follow for our pre-billing edits and our post-billing denials. And this really is a double-step process that you really need to take advantage of in order to be successful. As you can see, in both of these steps, there's a requirement for understanding appropriate coding and the use of modifiers, as well as the rules of engaging the payer and understanding the correct appeal process that each payer uses, because it will vary from one payer to the next, particularly how you handle those post-claims denials. And the next slide, please. So this is the slide that we've all been waiting for. What the results have been through this process. As you would expect, the effort for forensic coding has been well worth it. Otherwise, none of us would be on this phone call today. What's most significant is that the details that we've uncovered in the process has helped us reduce our claims processing issues and errors, as well as identify the local coverage determinations and the medically unlikely edits that we need to go after because they've not kept up with the treatment protocols that you see typically in academic medical centers. And then, of course, I think the most significant thing on this slide is that through this process, for the things that we have appealed, we achieved an 82% success rate, which just demonstrates that the approach to these things really is worth the effort. And as you can tell by this slide, the UPHS has gained significant additional unclaimed revenue that would have actually been left on the table had we not aggressively pursued these with the payers. So Jeff, with that, I'd like to turn it back over to you.
Thanks, Tom. The next slide is really just what the future holds. The presentation was set up to give you an overview of what forensic coding is and how we work with Tom and his organization. What our clients see and what they're looking for, obviously, is a smarter way to deal with the pending I-10 October 1st date of next year, increased satisfaction with the employees that they have and a way to maintain their internal resources, quicker turnaround, ways to get the cash back in as quickly as possible, not having to worry about vacations, holidays, fiscal reporting, end of quarters, the panic that most CFOs run down to the departments and start screaming that if they've got a board meeting next Monday, they need the numbers to look a little better than they do today. Then the ability to do it 24 hours a day, but with both internal and external staff, and having a true partnership that's working and looking just like the University of Pennsylvania, which we do. We wanted to... Go ahead, Tom, I'm sorry.
Yeah, Jeff, I actually just wanted to point out that, when you call this like the future state, I think that is important for the listeners to know that, as you said, we do both an onshore or nearshore and offshore type of solution to this. And sometimes for facilities, it's difficult from a political perspective to get that through. But I did want to say that if you're really having a financial responsibility about about how your health system or facility performs, you need to take into consideration the most cost-efficient way of approaching a problem. And with the kind of volumes we're talking about, that's really one of the things that you need to consider, political aspirations aside. I think that's one of the things that facilities have been kind of tepid about in approaching.
No, you're right, and I know there's always internal struggles. I think the results that we have proven, to your point, Tom, over the last 2 years now have certainly, from a return on investment standpoint, been a good investment and, a wise partnership for us both. I'd like to open it up to any questions or comments, and Tom or I would be happy to answer any specifics that you'd like.
Okay, well, thank you, Jeff and Tom, for your excellent presentation. We're now going to begin the Q&A portion of the program, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And again, we'll attempt to answer as many questions as we can during the time we have for Q&A. And any questions that we do not have the opportunity to address today, I would like to direct your attention to the slide up on the screen that you see. You may contact Michael Albrecht, who is the Vice President of EGS Healthcare Services. His phone number is 773-263-9173, and his email is michael.albrecht@ncogroup.com. We're now going to start with the first question that we have here. How do you price out a program like this?
So I can tell you a little bit about how, at least, when we worked with this company, we had an opportunity to do this either piecework or you could even do it on a contingency basis. One of the things that we at Penn like to do was to work on a contingency basis, because then both parties have that skin in the game, so to speak, to make sure that we're both going to get the same amount of attention to the services, because that's kind of the win-win situation, that we both get paid on that basis. So contingency is the way that we had actually priced it out.
Okay, great, thanks. The next question we have here, in recovery of the $3 million in 2011 and $4 million in 2012, any specific pattern on denials noticed?
I think that, Jeff, you can probably add to this. Certainly the medically unlikely edits that we talked about, I think, was a big deal in terms of some of the more expensive items that we were able to overturn and get that financial benefit on. And you can see by that success rate, the 82% success rate really does demonstrate that in a large sense, some of the payers are behind the treatment protocols that are necessary for complex treatments like cancer treatments that we use as an example.
Okay, Jeff, did you want to add something to this?
No, what our coders obviously do is go through the records in some detail, pulling out additional documentation that may be requested from the payer that for whatever reason was not shown to them at the time that they denied the bill. So sometimes it's a clarification as much as anything.
Okay, thank you. Can you please tell us how you are appealing for short stays?
There's not a big difference, meaning it either meets the criteria for admission or recommend changing to observation and bill as an outpatient. The short stays certainly are getting a lot of attention, the 1 days or the 2 days. So, looking back at what is present on admission and can it be justified, and if not, then rebuild as an outpatient visit in order to collect monies for the services rendered is what we do.
Thank you. This next question is, how are denials referred to you from the hospital? How are denials referred to you from the hospital?
We get a work list sent to us and have remote access into systems, which are multiple systems in the facilities. Obviously, it's across 3 hospitals, so there's many places that our employees look for each record that they're working on, and we submit back to the hospital either in their system, is how most of it's done, depending on the systems we're accessing, or back through worksheets that are then reviewed. Like I say, we have a good working relationship with Tom's staff and my staff, but it's through remote access into clinical systems and billing systems that our people work on.
If I could just add to that, we generally what happens is that on the pre-billing stuff, we obviously run things through our claim scrubber, and we've expanded the use of CCI edits really to make the claim as clean as possible, and we pull off the things that we feel that our staff aren't equipped to handle. Someone who needs that that coding expertise with modifiers, and that's how that first work list gets generated. And then obviously on the back end, as we hear back from payers, in a similar fashion, there are people in the business office that decide what is really something that we need our vendor to handle and what things we can handle internally. And that's really the second half of that work list.
Great. This next question is, can you provide an example of a coding denial that was successfully resolved?
Yeah, Jeff, I think probably one of the cancer treatment drug examples is probably the best one. I can start. I mean, I can certainly tell you from the provider perspective. Once as Jeff had mentioned before, that the records are accessed and an appeal letter is developed, pulling the most necessary components out of the record to justify the use of a treatment that may be in excess of what they use as a medically unlikely edit. And for the most part, there were a few drugs that our physicians were utilizing, and once things that were taken into consideration, besides the physician's decision making by itself, but possibly the weight and height of the patient and how the drug gets metabolized, and all of that being summarized in a letter written by a clinical person, such as one of the nurses that Jeff had mentioned before, with that copy of the letter goes through. Now, in some cases, we may have to wait 60 to 90 days for a response on that, but that's generally where a lot of our medically unlikely edits have been paid from. I couldn't remember a specific drug name. I'm not really that clinical, but I don't know, Jeff, if you had anything in mind.
No, unfortunately, I'm not the clinical one, Tom.
We're sorry. We're about bringing the dollars in.
All right, thank you. This next question we have, do you use external review organizations offered through the state?
The answer to that is no, and I'm actually was intrigued by that question only because, to my knowledge, I don't think that there are any external review organizations offered through the state of Pennsylvania. So I thought that was an intriguing question, but I'm not really sure. I don't think that our state offers that anyway.
Okay. What process do you use to appeal the Medicare MUEs?
Yeah, I guess I would say that that example I gave the last time is really the process that we use. It's a very labor-intensive process of pulling the records, getting the appropriate portion of the record to send along with your appeal letter, and the appeal letter basically summarizing the need for the type of treatment that was used. And for the most part, it's usually the units of a particular cancer treatment drug that may have exceeded either the recommended manufacturer number or quite possibly whatever the local coverage determination had as what they felt was, the medically likely limit on that particular drug. So essentially, it's just really the appeal letter.
Okay, great. Do you provide any type of root cause analysis to identify and track the cause of denials?
Yes, I touched on lightly we use the term CDI, but when we do send back information on a weekly basis, we have some of our more seasoned individuals put together a list of what we're finding and then review it with people in Tom's organization to say, these are some suggestions that we think will help reduce the number of accounts that we're working on. I could provide some of the details, or summarize some of that for you. I'm not the one that could tell you technically what they are, but I know we're giving back feedback on a weekly basis for the reasons for the denials.
Thank you. This next question is, have corrected denials led to a change in behavior on the client's part? In other words, has someone learned from their mistakes?
I think that's a great question, because it's very interesting when you start to review the results with the CFOs at the different organizations. We're a corporate billing office, so as we talk about this process of developing a method for outpatient denials, there has been discussions at the CFO level of, let's say for the sake of argument, the medically unlikely edit issue that I described before, that if the payers are going to continue not to pay at a level of the treatment that's currently being offered as part of our protocol, at what stage do you go to? Do you go to the provider and try and convince the physician that the level of care is excessive according to the payer, or do you continue to fight at the payer level to say that their local coverage determination is incorrect? And so far, I will tell you that we have not gone down the route of having the physician change their treatment protocol, particularly, if they think that this is the way that the treatment should go. There have been some other areas, though, I think, like in the utilization of EKGs, or I should say the overutilization of those. That's probably one of the number one things that we see where they might say that you've done too many in a day for whatever reason, and we've tried to make the providers mindful of that. So I think that we've been able to work through the education process in some of those, but it's a very fine line that you tread of having someone who basically works in the corporate finance division to dictate to the physician how they should be treating the patient. So I would have to say that that's probably a maybe answer to the question. I wouldn't say that we fully were able to change behavior, but we have in some small ways.
Okay, thank you. We have another question. The question is, because Medicare rules call for the cheaper option, repair or replace, what grounds do I have in ALJH when the patient is not very compliant or able to provide prior records?
Yeah, I'm going to tell you that in what we have done at Penn is kind of, in those circumstances, you almost have to throw yourself on the mercy of the adjudicator to basically say that you've done everything you could. One of the things that we try to get the physicians to document in the history and physical component are all the things that the patient has done prior to them either coming to see the orthopedic surgeon or obtain the records from physician to physician to have as part of the record. And so we've achieved some relatively good success in that, but if you've already passed that process and you don't have the records and you're now at the administrative law judge type of review, I'm not so sure that there's much you can do. And Jeff, I don't know if you have other experience besides that.
No, unfortunately, I agree with you, Tom. That's what we face.
So I think one of the reasons is that I think one of the things that you have to really take a look at your institution is, in addition to aggressively appealing these as much as you can, it sounds like that's what you're doing, I think you also need to try and stem the flow of these types of things, because I mean, we're experiencing the same thing at Penn. If you're coming in to get any kind of joint replacement here, and we have a very active orthopedic service, every single one of those is getting scrutinized by Medicare for records. It's just part of that deal that you need to be aware of. And so we have gone to the method of going to our physicians and improving that documentation from the history of physical perspective to include in the documentations that we send. And we've had some success on that.
Okay, thank you very much. So I want to thank both of our presenters today for your excellent presentation and for all of you who participated in the program today. We look forward to having you join us again for future webinars. And as a reminder, any questions that you had asked that have not been addressed today will be followed up with. And again, with the contact information you see on the slide that you see on your screen, you can follow up with Michael. This will conclude today's program, and have a wonderful afternoon.